Hello, Robert. I'm very good, thank you.
Good. Thank you so much. We had a preamble before we went live tonight. I'm absolutely delighted that you're here tonight to answer the questions that we have, but I'm also incredibly excited that you're going to be part of our International PBC Summit, which is happening in May. You may or may not want to say something about that and what we're doing and what you hope to get from the meeting. So you'd be invited to say something about that if you want to just now. You'd be welcome to.
I think it's we just said it's very exciting to at this meeting gathering clinician patient association group from all over Europe, Great Britain. I don't know if people are coming from North America as well.
And South America.
Yeah, representative from the industry, all the stakeholders around a table talking about the major issues of this disease, and I think it's an incredible occasion to meet and discuss and trying to tackle the issues we face in this disease, and maybe we can start to discuss tonight about some of these if anyone is interested.
No, 100%. So thank you. Absolutely delighted that you're going to be part of that. So thank you very much. Okay, if you've just arrived either here in Click Meeting or on Facebook, we are going to address some of your questions. Please do remember that this conversation does not take the place of your consultation with your own clinician. We're not here to give specific medical advice, but we're here to give general medical information as best as we can if the question allows. Marco, are you ready to get started?
I'm ready.
Okay, wonderful. Let's do this. So, right, question we have. So, somebody has PBC. They had the menopause 10 years ago. Joint, knees, backache. They say they're only 48, but they feel like 70. They're worried about they also have atrial fibrillation, and they were recommended Easy Flex. Now, I have no idea what Easy Flex is, but do you know if this could be harmful for liver disease or make PBC worse?
So I think it's a very specific question about the Easy Flex. I think is related to physical activity, I guess.
Okay.
So I mean the physical activities in general is very, is a helpful behavior. And this it might look paradoxal, but it might help. This is what we suggest to patients with chronic fatigue in order to fight fatigue and low energy. So the more physical activity you do, the more the lower is the pain, the lower is the fatigue. Again, this impacts also on the mood that will, and an increased mood will impact also on the pain, on the tiredness. So start off with some easy activity and build your stamina over the time, beginning with easy exercise. New exercise routine may be difficult at the beginning, but it will get easier with practice. And I don't think there is any disease, in general, for liver disease in general, PBC in particular, early stage, advanced stage. I think physical activity is good. Of course, patient with a very advanced disease, with already a decompensated disease, some sort of exercise are not recommended, like isotonic exercises where you not aerobic exercise and not suggested to patient with, for example, big ascites, high risk varices, but in general physical activity is good.
Okay, that's perfect. That's helpful. So my understanding that Easy Flex seems to be some kind of supplement from what I could make out, but I think it's helpful to talk about exercise and the impact it can have on the body. So thank you very much for that answer. Next question, if I may. So somebody is AMA negative. So first question is, what is AMA? And this person who's AMA negative has now they say GP210. Now they've read somewhere that anyone with PBC with a GP210, it's a nastier form, it progresses quicker. So first question, what is AMA? What is ANA? What is GP210? And is it true that if you are GP210 or SP100 PBC, that it is a nastier form or that it progresses quicker?
Yeah, so the AMA is the specific antibody. It stands for antimitochondrial antibody, and this is the specific antibody for PBC. Very few diseases have got a specific antibodies. So if you have a abnormal blood test, particularly abnormal cholestatic blood test, alkaline phosphatase particularly, and the AMA positive at a reasonable titer, you are very likely to have this disease. So it's extremely precise. There are a few persons who might have the disease without the AMA for some unknown reason. Some of these might have the antinuclear antibodies, and a particularly kind of antinuclear antibody are these GP210, which are antibody against a specific part of a cell. And so what some author described some times ago now is that those who have GP210 positive with or without the EMA might have a faster disease progression, might have more severe disease. I mean, today we cannot be entirely sure about this evidence, because it is an old evidence, more than 10 years ago, from two different courts, Japanese court, European court. But the court is a bit of a historical court, and we still haven't managed to validate this data on the current patient court on several thousand of patients. So while guidelines suggest to keep an eye on those with GP210 positive, I won't get too much worried if you have that. You will be treated the intensity of the treatment will be related to the activity of the disease, so the abnormal liver function test based on the stage of the disease, meaning the fibrosis, the finding the ultrasound scan, the fibroscan, but I won't get too much worried about that.
Okay, perfect. That's helpful. Thank you very much. So another question is a little fear-filled, so let's attack it and then see what we can come up with. So we've got somebody who has had PBC for about 10 years. They're 83 and they do have cirrhosis. Now, we don't know if it's compensated or decompensated, but they've been given 5 milligrams of amlodipine, maybe, for high blood pressure. They're concerned that is this safe to take with PBC?
Well, I mean, amlodipine is a drug to deal with high blood pressure.
Yep.
And I mean it's generally a safe drug. In some cases, it can cause some benign ankles edema. And if you get that, you stop it.
Okay.
It's pretty common. I think the issue on amlodipine might be that if you are cirrhotic with advanced cirrhosis and ascites, you have problem with fluid retention, amlodipine might not be the first choice.
Okay.
So you discuss with your GP, with your cardiologist, if there is another option. There are generally other options.
Perfect. So I'm just going to clarify that edema is swelling. So it can be swelling in the ankles or in the stomach. So just to clarify edema. So thank you. That's helpful. Next question, if I may. PBC and antibiotics. Are there any contraindications? Are there any times where you can't take antibiotics? So if you have, I don't know, tonsillitis or whatever, are there any complications with PBC and antibiotics, please?
No, there is no drug in general and no antibiotic that's been correlated with specific side effect related to the disease. So if you have an indication to take antibiotics for chest infection, urinary tract infection, tonsillitis, whatever, the antibiotic of choice should be the antibiotic, should be decided by the infectivologist, by the general practitioner, or by your physician. It should be based on having or not having PBC.
Okay. Perfect. That's helpful. So I've just had a comment on Facebook. John is saying I have my small glass of red also. So because it's Marco today, Marco is in Italy. We have changed the time, which hopefully will make this available to new people who have never seen a Q&A question session live before. And as I'm in Spain and Marco is in Italy, I thought it'd be a very nice thing just to have a little glass of red to salute your health. So, and John is on Facebook, and John is saying he's having a glass of red as well. So there we go, a little hepatotoxin. Right, next question for you. Somebody's saying they've been diagnosed 4 months. They're now taking urso. However, their skin and their hormones are now terrible. Is this normal in PBC? Is this normal with urso?
Well, I don't know what these hormones going crazy. I don't know what that means exactly for this person. But I mean, skin. I mean, generally, the urso is a very well tolerated drug by the majority. It can give some abdominal discomfort in very few patients, but generally is very well tolerated. Only like 1 to 3% do not tolerate it. And generally, I heard, I mean, apart from bowel discomfort, I've heard about issues with hair loss, more often hair loss, or skin problem or skin reaction. I never heard, and I don't think there is much in the literature. So something else need to be checked.
Yeah. Okay. Okay, that's helpful. Thank you. Okay, so we've got a couple of questions now about urso. So my first question is, what is urso? So you'll know it as UDCA, you'll know it as urso deoxycholic acid, but can you give us a little detail of that, please?
Yeah, well, the urso is like a biliary acid, and this is the first drug that has been registered to treat in the past gallstones, and we still use it in some cases of patients with gallstones. This is a drug approved, the first drug approved like 20 years ago by the FDA and the EMA in Europe to treat PBC, and it contains bile acid that are already present in our bile. So what it does is basically it's a drug that enrich our bile of benign bile acids, and it makes our bile more benign, more protected within the biliary tree.
Yeah.
It's a drug that is very easy to use, is very easy to use for physicians, is very well tolerated for patients, is very cheap, which is important as well. And the most important point is a drug that has been shown in PBC to be effective in, first of all, improving the bloods, which is something we want, but also in slowing down the disease progression, slowing down fibrosis progression, and an impact on long-term survival. So we know that after 30 years of use of these drugs, so we love this drug. It's effective and safe.
Okay. Okay, perfect. All right, thank you very much. So we've got somebody here who has, now they are overweight, used to drink alcohol once upon a time, but their bloods are now elevating. It seems they're not on urso, but their question is it common to have something like PBC and go years without symptoms?
Absolutely, yes. This is the answer. But it's, I mean, you can have a chronic liver disease and become cirrhotic after 30, 40 years of any liver disease without any symptoms whatsoever. And this happens for PBC as well. You can have PBC and discover it when it's after 20 years of silent disease. This is the liver. It doesn't give sign. So today with the awareness on prevention, we very often make early diagnosis of many diseases, including many chronic liver disease and including many PBC. So we very often diagnose PBC today at a very early stage, in a very like prodromic phase, when even before the disease comes up, like a person with completely normal bloods but anti-mitochondrial antibody positive. So it's and this is again thanks not to because the disease is symptomatic, but because we do screening or patient. All of us might take blood tests for work reason or for other reasons. So the other point I want to make is that PBC might be, there are symptoms that are very common in PBC. They are not specific for PBC, but they are very common in PBC, like we mentioned fatigue, chronic fatigue, and itch. Itch is very common in all kind of diseases where there is a blockage of the drainage of the bile from the liver to the gut, like in PBC. And so in all these kind of condition, you might have itch, chronic itch. So these are two symptoms very common, but not all patients with PBC experience this symptom. Maybe half of them might experience itch and fatigue, but the other half might be completely asymptomatic, even until the advanced stage. So that's not surprising what the patient suggested.
Okay. Perfect. Okay, that's helpful. Thank you. I appreciate that. I had another question that kind of comes from this. So, can we talk a little, please, about the relationship or non-relationship between the three parts of PBC? So, part one is your liver biochemistry. Part two is your histology, so your cell change in the liver. And then part three is your symptoms or your quality of life. Can you maybe talk about those three and how they correlate or not, please?
Yeah, so the way we monitor PBC today is through the blood test, because blood tests are very well correlated with the liver and biliary inflammation. I mentioned several times the anti-mitochondrial antibodies. There are blood tests like transaminases, alkaline phosphatase, GGT, that we showed many times in the literature that they correlate pretty well with the liver inflammation, and so this is already enough. It's a big achievement, and this is why drugs that get approved today are tested. So the drug that has been approved, the obeticholic acid, got approved showing improvement of the blood test. So in this disease, improvements of blood is very important, and this is something we want to achieve in clinical practice. And this is what your physician, your hepatologist will try to improve. Histology is it might be helpful, but not all the time in PBC. There are patients with PBC who never underwent liver biopsy in their disease course, and this is normal. Is not negligence of the physician. So the biopsy in PBC is not necessarily to make diagnosis. We know that. It might be helpful in some specific cases in patients with a specific, clinical phenotypes. For example, we want to perform a biopsy to exclude an overlap of the biliary disease of the PBC with another autoimmune condition, which is the autoimmune hepatitis. Or we want to find out whether a patient has got PBC but also fatty liver, because fatty liver is a very common condition after 40s, 50s, and particularly in those who are overweight, who are diabetic, who are high blood pressure. who are just aged, and so in this case, histology, so the liver biopsy, taking sample of the tissue with the needle might be helpful just to provide information. Sometimes the liver biopsy might be helpful also in patients who do not respond to drugs. And why it may be important, because we might find out, for example, in a patient who do not respond to the URSO, that he might not have that disease. We might, make a mistake in the initial diagnosis, or he might have a more aggressive disease with very severe loss of bile ducts, or maybe other issues behind this lack of response to the drugs.
Yeah.
We don't normally do liver biopsy in like a regular or longitudinal biopsy in patients with PBC. So in general, these are the kind of setting where we do liver biopsy. The third point, the quality of life. I mentioned about the symptoms. These are the symptoms that we look for. Other symptoms we look for are dry mouth and dry eyes. They're very common. And they are very, very often present in individuals with PBC. And what the clinical research is very active on symptoms, but we still do not have a therapy that improves symptoms. So when sometimes we are not very good, and we are not very thorough in our visits to ask about all the the symptoms, the fatigue, how all the details about a specific symptoms, about the fatigue, about each and about the others. Sometimes because we don't have anything to improve them. But actually, we should. I think we already got better. We talk more about that in when we design clinical trial. We are talking about that here. We talk, we do lots of education between us, with the general practitioner, general gastroenterologist, with patients. So we talk more about that. So it means we give more relevance to the quality of life, and not just the improvement of blood tests and of the liver histology. So the other important point is that we are trying to raise awareness with the industry that fatigue and itch are important, very important for us and for patients. And it's very nice to know that there are several trials in cholestatic liver disease that only tackle symptoms. And I think this shows the effort of the entire community to deal with this.
No, it's a great point. I'm glad you brought that up. So I'm currently in Barcelona for an itch event, which is absolutely great. And again, we were invited to present the patient experience and what does itch mean for patients living with it every day. But it's incredible to think that right now we have 3 companies investigating itch. We have one company that's exploring fatigue and brain fog. We have one company that's exploring fibrosis within the liver. And we have 2 companies that are exploring new possibilities for disease progression and the management of that. And that's an incredible amount of activity in terms of the people, the gathering of intelligence and knowledge and wisdom that are in the room, all talking about PBC right now it's such an amazing time to be part of the community and to see these changes happen. So yeah, it's wonderful. Okay, sorry, Marco, we took a sidestep there, so thank you for indulging me in that. Here's a question for you. Gosh, they're testing me today. Levato reticularis. Now, that sounds like a Harry Potter spell. So please, can you tell us what that is, and is it related to PBC, please?
Well, the levato reticularis is, it's thought to be something related due to the spasms of the blood vessels, or anyway, a problem of the blood flow near the surface of the skin. It makes the skin look mottled in a sort of a net pattern with clear borders. So this is something that we sometimes see on the legs. but I mean, it's not a disease itself. Sometimes it's physiological. There are healthy people showing these liver reticularis just because they are chilled, because it's cold. There are forms of these that are presented since birth.
Yep.
Sometimes it can happen after drugs.
Okay.
But also this is been described also in autoimmune condition, the Raynaud phenomenon. I think in your community you might talk about the Raynaud syndrome and the Raynaud phenomenon, which is again it's an issue of spasm of the vessels, of the peripheral vessels, due to the patient with a susceptibility to have this issue when they are exposed to low temperature.
Yeah.
So yeah, it's more than liver reticularity, the issue that is very often in PBC and in chronic liver, in autoimmune liver disease is the Raynaud phenomenon, which is again is something pretty similar, something related to the circulation of the bloods when you are exposed to low temperature.
Okay, perfect. Thank you.
And it's something that needs to be discussed, probably brought to a rheumatologist who is going to do some specific tests, like a capillaroscopy, to study all the small blood vessel and see whether the reaction to the change of the temperature. So there are a way to prevent these issues. There are treatment in those with a serious problem, but it's something we need to explore also during the visits. It's something that sometimes patients do not bring them. Is not they don't associate to the liver, but it may be part of the same autoimmune family of problems.
I'm with you. No, I understand. So thank you. Okay, that's helpful. All right, next question again. So coming back to PBC. So the first question we have, is there any information you can give about heart disease in relation to PBC? So that's the first part of the question.
Heart, I mean, we don't see specific autoimmune heart disease in patients with PBC or any kind of heart problem, apart from ischemic heart disease. With patient with PBC, like any other individual, has risk of developing a heart problem due to ischemic issues. We know that in PBC, particularly in more aggressive PBC with elevated blood tests, this patient might have high cholesterol level, and we know that elevated cholesterol level in the blood might increase risk of cardiac problem, heart problem, and stroke. And so, patient with PBC, like any other patient, if the cholesterol level are high, they should be assessed by a GP, a cardiologist, to assess the cardiovascular risk. And if the cardiovascular risk is increased because of their age, sex, because they smoke, they are diabetic or whatever, or they got already organ damage, they should be treated properly with statins and all the high blood pressure drugs, and they should undergo proper cardiovascular assessment and management.
Okay, perfect. That's helpful. Thank you very much. Okay, we've got somebody who has PBC and Hashimoto. So for those of you that don't know, Hashimoto is a condition that affects the thyroid. So the question is, they're looking for dietary advice that is best for Hashimoto. And they found that they should be taking grain-free and take probiotics. But they've also read that probiotics are not great with liver disease. So there's some confusion. Are you able to help in any way, shape, or form?
Okay, many questions in one question. So, I mean, there is not a one-size-fits-all diet for everyone with liver disease or everyone with PBC. We got rules of diet in patients with cirrhotic disease, so very advanced liver disease. We know that patients with very advanced liver disease need to have a specific diet with a specific amount of proteins, specific type of proteins, low salt diet. But I mean, in patient with PBC should again, there is not a specific diet. I think it's an inflammatory disease, and there are diets that might be more helpful with inflammation. But I mean, the suggestion are the overall suggestion is to follow a healthy Mediterranean diet, which means eat lots of fruit and veggies. To opt for moderate amount of lean meats. The amounts is avoiding meats every day. Prefer the unsaturated fats, extra virgin oil, nuts, fatty fish like salmon. Choose carbohydrates, whole grains, and complex carbohydrates, cereal, crackers, rice. Coffee seems to be good. A patient always going to, they come to clinic and say, look, I don't smoke and I don't drink coffee. But I mean, there is this stigmatization of coffee. I mean, in a really decent amount is apparently seems to protect the liver. Something that is a killer, particularly in patients with inflammatory condition, are saturated fats like cream butter, but also the beef, pork. So we should go with this food also always in moderation, avoiding excessive amount of dairy meats, bacon, sausages. We need to be careful with high sugar. Sugar sweetened beverages, and added sugar to food. We know that we need to reduce sodium in cirrhotic, but also in general, you need to aim to reduce sodium in our diet. And you mentioned the probiotics. So probiotics are good bacteria that we give them with the aim to change the composition of the bacteria in the gut. We generally prescribe the probiotic after antibiotic therapies. There is no recommendation for patient with PBC to take probiotics. We in patient with the chronic inflammatory bowel disease, IBD, Crohn's disease, ulcerative colitis, we might suggest specific antibiotics, but in general, in cirrhotic, in PBC patients, we do not recommend specific to take antibiotic unless they again undergo antibiotic treatments. Then there is the manipulation of the microbiota, but it is a completely different topic, and is related to manipulating the microbiota as a targeted therapy, and it's something that it's under study in primary sclerosing cholangitis and in other conditions.
Okay, perfect. That's helpful. Thank you. Okay, next question. So we've got somebody with PBC who's been on Urso for a year, and their ALK phos is still somewhere between 500 and 550. So they're concerned that the Urso might not be working. Can you suggest anything else?
So first of all, I think it's missing the starting point. So the 500 depends if before starting Urso they were 1,000, and so there was an improvement. So it's important to see whether there was any improvement, which means that the drug is not really failing, but probably the disease was very intense. First point. Secondly, the drug might generally work, generally improves the blood, probably in 100% of patients. In some, does not normalize the blood. Now, if it does normalize the blood, it might be related to the fact that the dosage is not correct, and so you need to the hepatologist needs to optimize the dose, 13, 15, 18 milligram per kilo of drug every day. That might change with the weight change of the patient. Drug interaction, but generally unless someone is taking the cholestyramine, the resins for the itch that might bind everything and urso as well.
Yeah.
There are no several other interactions. If the drug generally doesn't work, I mean, you need to discuss with the hepatologist to see whether there is it is a true no response. You always need to question the diagnosis, the initial diagnosis, whether it was correct. It's possible, to challenge the diagnosis in case of lack of response, and then probably there is. If this is not the case, there is the option to start a second line therapy, and there are second line therapies. But the treatment failure can be declared after 6 to 12 months. So if I don't remember this person if he reached or she reached the 6 months. If not, I will wait 6 months to see the full response.
Yep. So it's been a year.
A year. So yes, I mean, whatever was the starting point, somewhere with 500 alkaline phosphatase with a upper limit or normal range of 200, 300, I don't know.
Right.
There may be an indication to start the second line therapy if that person has been very adherent to the therapy in the first instance.
Okay, perfect. That's helpful. Thank you. So I'm reading a question now, and I'm just trying to understand the question, which is why I have a confused face on. So we have quite a complicated personal background to this question, but I'm going to come to the crux of the question, then we can take it from there. So somebody has been on obeticholic acid, and they've been recommended to now keep taking the obeticholic acid for a longer term. Do we have any information on the long-term effect of taking OCA?
So now we got a pretty good data up to 6 years, I think, from the clinical trial in terms of safety. So we know how the drug works. We know how we can check the efficacy and the safety. We know when we shouldn't give the drug. So we know quite a lot about this drug now. Of course, the long-term data, 10, 20 years, we need to wait a little bit. But I think the current data available are quite reassuring in terms of safety. For example, we know that we shouldn't give this drug to patients with very advanced liver disease. This is what physicians believe. Physicians have tested in their clinical practice. This is what the regulatory bodies, FDA and EMA, recommend. Person with a very elevated bilirubin, and about the definition of elevated bilirubin, we can talk, we can discuss. Patient with a cirrhosis stage child PUG B or C shouldn't receive the drug. Patient with a severe itch can receive the drug, but the itch should be controlled first, and then the drug can be started and titrated based on the symptoms. No other major side effects. I think the drug, apart from this, apart from a progressive liver disease in patient with already advanced liver disease and itch, we haven't seen dangerous side effects. In terms of efficacy, while it works in some, it doesn't work in others. Like it works in the early stage of disease, up to 50% of patients improves very well the blood test. If we talk about cirrhotic patients who manage to take the drug, who do not stop the drug, 1/3 of those as an improvement, an important improvement of the blood test.
Okay.
And when we see improvement of blood tests, we meaning this translating, long-term survival.
Yeah. Okay, I get that. Thank you. Here's a cracking question for you. Does URSO help reduce itching?
Yes and no. There are many patients complain of itch after starting URSO. Not all patients. Many patients have each improvement with URSA. If you give URSA, for example, to pregnant women with an itchy disorder, which is a intrahepatic cholestasis of pregnancy, which is very common condition, very common and generally benign condition, you give it URSA and you treat the itch. And also in PBC, very often you give the URSA and the itch improve, but sometimes it can happen that the itch, for some reason, might get worse with the URSA. So it's not an unreasonable question.
Okay, perfect. Thank you. That's helpful. Okay, next question, if I may. So this is about PBC and cholesterol. So I know we talked about this earlier on, but I'm going to ask you now, this is where I'm at the absolute limit of my knowledge. If I say to you lipoprotein X, is that the type of cholesterol that's high in people with PBC?
Well, I mean, the PBC and cholesterol has always been an open issue.
Okay.
Because in the past, so the cholesterol gets eliminated through the bile. And if the bile drainage is blocked, of course, the cholesterol remains in the blood, it goes back into the blood, and we can see it during the blood test. So now historically we thought, or they thought, that high cholesterol in PBC is not associated with heart problem, with cardiovascular problem. But actually, more recently, several evidence in the literature show that high cholesterol in PBC is associated with heart problem as much as patients without PBC. In other words, we should treat the high cholesterol of PBC like we do in patients without PBC, as I mentioned earlier. So, of course, many patients with PBC might have HDL cholesterol, so the good cholesterol that is high. And again, this should be, the cardiologists and general practitioners have their own score with the value that they need to fill in of good cholesterol, total cholesterol, and all the other risk factor of cardiovascular event, and they should calculate this as an inpatient without PBC. This is an important message, that we shouldn't neglect high cholesterol in patients with PBC.
Okay, perfect. That's a helpful answer. Thank you. Okay, next question. Blood pressure is pretty high, but varies a lot. Again, with PBC in mind, should we be taking medication? Should we not be taking medication? What guidance can you provide in terms of a patient with PBC who has variable, albeit high blood pressure?
I mean, it's unrelated to the PBC. It's, blood pressure tablets do not affect the liver. I mean, the majority of drugs are metabolized into the liver, but I mean, it's like we mentioned, antibiotics. Also, blood pressure tablets can be taken safely in a patient with chronic liver diseases. I mean, every drug can, in theory, give some liver toxicity, but we cannot anticipate that. We cannot predict that. We will only experience once the patient takes the drug. Tablets for high blood pressure, they are not the most common drug that give liver toxicity, so I will be easy on that. The only thing, as I mentioned at the beginning, there are in patients with advanced cirrhosis, ascites, water retention, chronic kidney issue related to the liver, we should be careful to specific drugs like ACE inhibitor, sartans. But I mean, the hepatologist should advise on that.
Yeah. Okay. Perfect. That's helpful. Okay. Next question. White blood cells. Is it common to have low white blood cells in PBC?
Not really.
Okay.
In a patient with only PBC without any other comorbidities, we normally do not see low white blood cells. Okay. We might have low blood white cells in patients with other with low platelet count, with low hemoglobin, what we call pancytopenia, so a reduced number of cells in the blood an overall reduction that is related to the spleen uptake of all the blood cells.
Okay.
Platelet, white cells, and the red cells.
Okay.
But isolated white blood cells in PBC is not a problem.
Okay, perfect.
There's no relations, I mean.
Okay, perfect. Next question. Can you tell me if bile acid diarrhea is connected to PBC, and does cholesterol work?
Did you meant to repeat again? What is related?
Is bile acid diarrhea.
Okay. No, it's something that we don't. So you might have diarrhea for any other reason, but generally patients with PBC do not experience chronic diarrhea.
Okay, and cholesterol, would that work for bile acid diarrhea?
You know that probably is a number that I don't know. What exactly is cholesterol?
I'm assuming it's cholestyramine, but I don't honestly know.
Okay, okay. It's the commercial name is different in Italy. So, one second. So the bile acid diarrhea, I mean, it's something that we don't really. We see bile acid diarrhea in patient who takes we mentioned before this webinar the trials in tackling itch or in trying PBC with the IBAT inhibitors, so inhibitors of bile acid reuptake in the gut, and in this with this drug the bile acids are released massively with the gut, with the stools, and in that case you get bile acid diarrhea. But in PBC, you don't really, patients do not experience that.
Okay, perfect. Thank you. Now I'm going to ask a vague question because I don't know much about this. There is talk of a nanoparticle and as a cure for PBC. Do you know anything about this at all?
Yeah, I mean, I have colleagues who work on that. So, I mean, the nanoparticles are, as the word says, very small particle or matters that are used, at least they are under test in medicine, in several fields of medicine, as a carriers of drugs. So there's been studies ongoing testing the nanoparticle as a vector, as carriers of like drugs, like steroids or other drugs, specifically to the liver. So it's he comes in within the field of personalized medicine, with very highly targeted medicine. But we are at a very, very early research stage.
Okay, perfect. That's helpful. We've got a relatively newly diagnosed patient who's concerned because they've been told they have cysts on their liver and kidney. Should they be concerned?
Well, I mean, this needs to be seen in clinic with ultrasound scan, a CT scan. In general, cysts in the livers are very common. Even if they are big, they are generally biliary cysts. Benign. They might grow, but they are benign. And very commonly we see also renal cysts, but you need to see, I mean, it's very common to see this in their sporadic appearance, but there are diseases that are genetically driven diseases with polycystic disease of the liver and the kidney. But I don't know if this case needs to be seen in detail.
Okay, perfect. That's helpful. Thank you. And I've been asked to ask you, what about hormones? So I'm assuming we're talking about hormone replacement therapy. So can you talk to me about HRT and PBC, please?
We don't have any issues with the hormone replacement therapy. it is not contraindicated. We need to bear in mind, particularly at the diagnosis stage, that this therapy, well, hormone therapy in general, also there are men who take some hormone for medical reason, or for a sport reason, or for other reason. So we need to bear in mind that hormones might give hepatotoxicity, and so this is important, particularly at the diagnostic stage. So yeah, it's something needs to be evaluated, but in general, if we talk about HRT, it's generally is not an issue in patients with PBC. Of course,
Okay.
it may be a problem in patients who have, other than PBC, also like lesion of the liver, like hyperplastic lesion, like the adenoma, like benign tumors of the liver, which are very common in women, and these might have estrogen receptor on their surfaces, so they might increase with the hormone therapy. So we need to be careful to these things. But in PBC specifically, we don't have any evidence that it might be detrimental.
Wonderful. Okay, thank you very much. Herbal supplements. Any thoughts on herbal supplements and PBC?
Yeah, well, we don't have any indication to provide these to improve symptoms or as a disease modifier. Herbal supplements, there are many warnings on their use by several regulatory bodies. Also, the liver European guidelines suggest to avoid them unless they are necessary for they are required for some reason. But we know that there are several herbal remedies in the blacklist of the liver tox drugs. Several herbal remedies might cause, in a specific patient with a susceptibility for that molecules, it can give liver toxicity or up to liver failure. So we need to be careful. We suggest in general not to take herbal remedies. We know also some very healthy products like green tea, curcuma. They got very good property, but they've been related also in some patients, not in everyone. In some patients who is genetically predisposed, they might give toxicity, which doesn't mean that the curcuma and the green tea are toxic. It means in a specific patient, like anything, like any drugs, like anything different, over-the-counter drugs and whatever. They in a patient with a high susceptibility to the drug, which means a patient who does not metabolize the drug properly, it might cause liver toxicity.
Okay.
But again, probably one day we will end up having, all of us, a genetics test on the bloods, and we will get our schedule, our map of the drug that we can tolerate and drug we should avoid. One day will be like that. Today we see us not still there.
Okay, no, that's helpful. All right, perfect. Thank you. Now, we know that people with PBC will often have a UTI, a urinary tract infection. Is this linked to URSO? Is it linked to PBC? Is it coincidental? What can you tell us?
So what the literature says is that the UTI is very common when you collect the history of patients with PBC, and this is related to related to some of the hypotheses of the pathogenesis of how the disease starts, because we still don't know how the disease starts. We know that you need some genetics that predispose you, several genes that predispose you to get the disease, but then you need a trigger, something that trigger a disease immune system, and the trigger might be many culprits have been described among these infection of the UTI. Frequent UTI have been associated with PBC, but we don't really know. Patients with PBC is not true that they develop UTI more often. That's not but that's not my experience, and that's not what is reported in the literature.
Right. Okay, that's helpful.
Or if it makes sense.
Okay, perfect. So again, we've got another person who, again, newly diagnosed. They've only been doing 3 months, and they've got constant itching now. Now, it seems to be since they've started the urso. So they've tried tablets, capsules. They're now on urso in liquid form. But they're just saying, can it take a while for the body to adapt? Should I persevere with it? All of those kind of questions. So any thoughts or guidance?
So I mean, urso is not really the drug for itch. So urso is the drug that should be prescribed for as a disease modifier. For the itch, there are other drugs, and we got a few drugs now. And I mean, this needs to be discussed with the hepatology. There are several lines of drugs. We got the resins, the cholestyramine, which might not be very tasty, but is pretty effective in many. There are the fibrates. We got the trials data of the fibrates being effective on itch. And the fibrates, which are drugged to treat the high cholesterol, high triglycerides, they are the first line therapy to treat itch in PAC, in primary sclerosing cholangitis. And so probably when the guidelines on PBC will be amended, will be updated, also fibrates will become the first line for itch also in PBC. There are some caveats in use of fibrates in terms of potential for liver toxicity, renal toxicity, but these things, pros and cons, need to be discussed with the physician. And then there are other drugs, the rifampicin, which is not super easy. Not many, all hepatology might be familiar with it, but it's very useful. It's very, maybe very effective. And there are many, but these are the most effective. But there are other lines of therapy beyond the UDCA.
Okay. Perfect. Thank you very much. Marco, we have run out of questions. Good job. So thank you so much. So last question from me. So obviously I'm looking forward to seeing you at the summit. I'm looking forward to seeing what the conversation brings. But you, historically, you've done lots of journal papers in terms of identifying at-risk patients. You've been involved in clinical research and all those kind of things. So my question to you, just to close the session, what is the most exciting thing that you're working on within PBC at the moment, and what should we be keeping our eyes out for?
Yeah, but now we got another couple of hours to talk about it. So it's exciting, the atmosphere. You mentioned all the trials that are ongoing, all the therapeutics in development. There are, as a disease modifier, there are probably 4 or 5, just as a disease modifier, with 2 or 3 different mechanisms of action. There are, all the trial environment is very exciting. Particularly those related to the improvement of quality of life. As basic research is, we still don't know how to cure the disease, whether we can cure the disease, whether we can eradicate the disease, whether we can reestablish the tolerance of disease. And actually, there are studies in English colleagues are working on that to reestablish the tolerance. That it's a concept not just related to PBC, but also to the other autoimmune condition. I think this is pretty exciting. Another exciting point is the biomarker discovery field. So we got very strong data showing the FibroScan is a very good tools that we can see. It's easy to use. Everyone has it in his clinical practice, and it's very useful on a daily basis, and also in clinical trial design as an endpoint in clinical trials. So it's less frustrating today treating individuals with PBC, because we got more weapons, we got more possibilities to better manage these patients. So it's an exciting time to be in this position.
So we've got one more question, and it's a great question. So I'm going to ask you the question, but one of the things we didn't talk about was the Bez-Oka trial, which is going on in the US. So this might be part of the answer to the question, but we have been asked, do we know why bezafibrates have not been licensed in the US?
I have to admit I'm not been involved in the design and I'm not update on the data of the trial.
Okay. But, so for example, in the US, if they're going to use fibrates, they'll use phenofibrates.
Yeah.
Because bezafibrates are not available. Do we know why bezafibrates are not available in the US?
No, I'm not aware of that. But it's, I mean, the US they only approve drug that being tested in the US. We saw that, for example, for terlipressin, that we use in Europe, we've been using for several years after a trial that showed that it works in specific conditions. But in the US, it's they ran a trial just recently, probably last year, a couple of years ago, and only after that trial, it got approved or licensed, and so it's a different like legal framework, I guess.
That's a good point. Yeah, good point. Right, watch this space. We will find out what we can. So we'll see if we can harass any American doctors for an answer on that. Marco, thank you so much. It is 10 o'clock in the evening over there in Italy. So thank you so much for giving up your time.
Thank you very much for inviting, and thank you to everyone who joined.
It's been an absolute pleasure, sir. So you take care, and if we don't see you before, we will see you at the summit in Edinburgh. So you take care.
Fantastic. Bye-bye. Have a nice evening.
All the best. Take care. Thank you.
Bye.
Okay, if you're in the room, thank you very much for attending and joining us here. I hope you've enjoyed it. And that's it. So now I'm going to stop recording.